both operable patients and non-operable patients using different forms of radiation, and I think Dr. Gerald will go further in detail about that. What I want to show here is that this is a randomized trial where radiation with rituximab was combined versus radiation alone, which of course is in locally advanced head and neck cancer at the moment is not the standard, but that will be discussed later. In this trial, the patient characteristics were quite balanced, as you see here, for age, gender, and the site of disease, the primary site of disease. And it shows a favorable outcome with respect to local regional control in favor of the combined treatment, and a similar observation was seen for survival with p-value both of 0.02. I think the great importance of this trial is the fact that, contrary to what we have seen when we combine chemotherapy and radiation, is the fact that the mucositis is in fact not increased. And that's very unusual, because you know that in all our trials where we now use chemoradiation, that is one of the major problems we are facing. And the fact that here you have a better local regional control and survival and not an increase in the mucosal reaction is, I think, a very fascinating observation. Also, you see here the patients that were candidates for larynx preservation. There's not much difference between these two curves. And important in that respect is that those patients who receive surgery, a subset of patients from that trial, did not seem to have a significant effect on wound healing, something that we are a little bit worried about when we give these agents in combination with radiation, because you may expect some effect on the skin reaction. So I think that what we can conclude from the data we have now is that there is a synergism between platinum compounds and this is a mistake, and cetuximab. There is survival benefit with recurrent and metastatic disease, but there is a question mark here because there is no randomized trial and no data on that at the present time. There is survival benefit in patients with locally advanced disease when you combine it with radiation, but there is only one trial, and you may question whether that is sufficient. EGFR inhibitors and radiation could replace radiation alone for those who have intermediate risk locally advanced disease. It's also a possible alternative for patients who are candidates for chemoradiation when they are not able to tolerate that. And I think that, and this is of course also for discussion, that for the future trials that we need to do, it's chemoradiation versus EGFR inhibitors and radiation. It's chemoradiation plus or minus EGFR inhibitors. We have to look at induction chemotherapy followed by chemoradiation plus or minus EGFR inhibitors. Induction chemotherapy plus or minus EGFR inhibitors. The interaction of EGFR inhibitors and other cytotoxic agents, and now there is a flux of studies ongoing, and we should look at interaction of EGFR inhibitors and other biologicals, and I have shown you some of them, but there are more at the moment ongoing, and I think that that's a whole field of research that we're going to see for the coming years. Thank you very much.